We segued on from that in our session to using cell-based therapies targeting these different viruses and trying to see how these therapeutics can really perform alone. But what we didn't discuss today is actually where I see they will have utility is in a combination strategy, either with chemo or other targeted therapies such as antibodies, checkpoint inhibitors, etc. So that's where I sort of hope to see the T-cell therapy field go. Rich, you brought up a very good point though at the end there about actually for the virally driven cancers, where that's really the biggest population exists in the developing world, and what are we going to do for them? And so I did bring up this concept of a GMP in the box to address cell-based therapies, but what are your thoughts as a group, because we all have experience with virus-associated cancers, what are your thoughts for what other low-hanging fruit options do we have in terms of agents that could be easily accessible to the developing world? So maybe I'll start with you, Rich, and we can...
Yeah, I think that easily accessible agents is a relative term, and we have a consortium, the AIDS Malignancy Consortium, that conducts trials in sub-Saharan Africa, and getting common drugs such as cyclophosphamide is not really all that straightforward in those settings. On the other hand, we have pharma partners who are very dedicated to the cancers that are occurring there. And so Kaposi sarcoma, which is an HIV-associated tumor, doesn't have to be HIV-associated, but they're all caused by gamma herpes virus HHV8, also known as KSHV. Celgene is actually supplying pomalidomide for a clinical trial there with a real conviction that if it's a positive trial, they will help make pomalidomide available for Kaposi sarcoma there. So this is not only a scientific question, but a philosophical question, as you pointed out in the session, of how committed people are to bringing therapies that will work and are available to patients in sub-Saharan Africa and other resource-limited settings.
So Mark, when you answer your question, what I would you like to put in context is, you talked about the toxicity of interferon alpha over a year. So, okay, now we're thinking, even in the developed world actually, but in the developing world especially, maybe that's not such a great option, and we have many more immune-based therapies now available to us. So if you had your magic box idea, what would be your go-to agent, do you think, for that disease?
Well, this is gonna sound a little old-fashioned perhaps, but vaccines. So one of the things that is true, at least in Burkitt lymphoma, is that's a lymphoma that's driven by EBV. And in the developing world, it happens at much younger ages, and it grows very quickly. And it's not just the fact that they get EBV at younger ages. They actually, in many cases, have co-infections with other things that are preventable, such as malaria and other infections that actually predispose them to get Burkitt lymphoma. So I think at least the most immediate thing, if we want to make impact there, in areas that don't have access to vaccines or other ways of preventing your immune system from getting to the point where a virus can overtake it, preventing your HIV from impairing your immune system. I think that's going to make the biggest impact as far as numbers. But the interferon story that you mentioned also brings up a separate point that I wanted to make with respect to the duration of therapy. So we gave patients therapies for many years with that, and that became very toxic. And we're seeing in some situations where some of our newer medicines are given for indefinite periods of time. And I think that's a different type of toxicity, a financial toxicity. And for example, the studies that we are doing, even with immunotherapy, we always give the patient an opportunity to stop the therapy and see if that maintains the response. And we know in Hodgkin lymphoma that that's occurred with checkpoints. So I do think this indefinite therapy is probably another thing we could discuss about how we want to, approach things and within our resources.
So Ruth, when you answer your question, I'd also like you to answer it in the context of EBNA1. You brought up the very good point that EBNA1 is expressed on all latency 1 to 3 tumours. So why haven't we got the magic anti-EBV EBNA1 target, with small molecule vaccine even? Why have we not had a home run by targeting EBNA1? Do you have any thoughts about that?
I think it's only in recent years that people have really started to push for these things, and now we have several sort of challenges in terms of for funding to try and eliminate EBV-associated lymphomas or EBV-associated cancers. So I think there's now much more of a push to develop these things, and I find it harder to answer the question here because I don't treat patients, but in the long term, I think that trying to get specific inhibitors of these viruses, trying to develop vaccines is important because we actually know that the viruses are causatively involved here, whereas for most cancers we don't have a clue, so we should really be going after that. And I think EBNA1 is required to maintain the EBV genome in these lymphomas or other cancers caused by EBV. So if you can eliminate EBNA1, you will lose the genomes from the cells. And clearly they're being maintained, so they're needed to maintain the tumours. So I'm not sure why we don't have them, but I think that going after these is definitely a good idea.
Yeah, and I think that's what I would like to take away from this, that actually we are in a very unique setting, actually having a virus-associated lymphoma to target, and we should not ignore the fact that there is a virus there that we could target in the EBV setting, and we should not ignore the fact that this could be an opportunity to also effect a cure for HIV. And people might say that's really perhaps a wild thinking, but it is a unique opportunity. So I would like to take that to be the take-home message, that we have a very unique opportunity, and we should really drive the field to really capitalize on that unique opportunity and really target the viruses as well as the tumor itself. And any take-home thoughts?
Yeah, I agree with that completely, but Mark's point about prevention, I think, should not be underestimated. So if in Africa, if greater access to anti-HIV therapy were available, and it has been made more available under the PEPFAR that President George Bush had started years ago, more and more people in Africa, millions, are being treated for HIV now than they were before. But what we need to do is improve that, because the more anti-HIV therapy you've got, the lower the risk of lymphoma becomes. And if you could also develop preventive strategies for KSHV infection and EBV infection, that again would prevent a lot of these tumors. Targeting the tumors after they've developed will continue to be important, and I think some of the cell therapeutics that you talked about is really one of the more promising ways of doing this. That's my personal opinion.
Okay, well, I'm not going to argue with you there. Mark, what is your take-home thoughts?
No, I think you make the right points. I mean, we use immunotherapy. Increasingly, we know what works in cancer. And the nexus between virus and cancer is here. And so it makes it even more likely that effective strategies, safe strategies, will be effective in these tumors. So it's very exciting right now.
I would agree with that too. Ruth, you're the last one.
Well, I just want to take up on Mark's point about other things that are going on. So for EBV positive Hodgkin lymphoma, we know that material deprivation is a risk factor, less education, and so just improving health and getting out of poverty will be an advantage. Then the other group of cases of EBV positive Hodgkin lymphoma that follow infectious mononucleosis, we know so far that EBV vaccines don't create sterilizing immunity, but they can prevent infectious mononucleosis, so they do have the potential to decrease the risk of that disease.
So these are all fantastic points, and I'd like to thank you all for speaking at the session today and partaking in this video. So thank you.